السلام عليكم. أنا حسن طارق، طالب كلية الطب مرحلة 5. Today I will talk about seminar on fixed drug eruption, mechanism, diagnosis and management. Fixed drug eruption is drug-induced skin disorders appear 2 to 24 hours after exposure to the causative drugs, classified as type 4 hypersensitivity reaction and significance in clinical practice. Related to pathophysiology, role of T cells. Memory T cells localized in the skin get reactivated upon re-exposure to the causative drugs. Cytokine-mediated inflammation leads to localized tissue damage and the importance of melanin in post-inflammatory hyperpigmentation. Related to clinical feature, characteristic lesion. Characteristic lesion of fixed drug eruption is well-demarcated, round or oval erythematous patches, and may evolve into a blister or ulcer as we see here. And the common sites are lips, genitalia, hand, and feet. Re-exposure reaction. After subsequent exposure to the causative drugs, the lesion reappear at the same anatomical site and intensification with each exposure. The associated symptoms are rhinitis and burning sensation. We see here one of the complications of fixed drug eruption is generalized bullous fixed drug eruption as the result of subsequent exposure to the causative drugs. And we see here multiple lesion of erythematous patches after subsequent exposure. On the first drug exposure, there is usually only one lesion, but subsequent exposure can result in multiple lesions. Once the drug has been stopped, the lesion resolved and may leave an area of post-inflammatory hyperpigmentation. The common causative drugs. Antimicrobial, for example, sulfonamide, tetracycline, and fluoroquinolone. Non-steroidal anti-inflammatory drug, for example, ibuprofen, naproxen, and diclofenac. Antifungal, for example, ketoconazole, and anticonvulsant, for example, phenytoin and carbamazepine. And also oral contraceptive can cause fixed drug eruption. Related to diagnosis. Clinical diagnosis dependent on temporal relationship between drug intake and lesion development and the recurrence at the same time upon the same site upon re-exposure. Confirmatory test, we can do batch testing in the non-eroded skin area and control the drug rechallenge under supervision. Related to management. Firstly, we should immediate discontinuation of the offending drugs, and then we can do symptomatic treatment as use of topical corticosteroid for inflammation and oral antihistamine for itching and burning. In the severe cases, we can use systemic corticosteroid or immunosuppressive therapy. The patient education is very important as we encourage the patient to maintain a list of the drug allergy and wear medical alert bracelets may be benefits in the emergency. Related to complication, post-inflammatory hyperpigmentation, secondary bacterial infection, and rare systemic involvement in the severe cases as generalized bullous fixed drug eruption. Related to prevention, avoid exposure to the offending drugs, patient counseling on recognizing early symptom, and use of alternative drug with a lower risk of hypersensitivity. The conclusion is importance of early diagnosis and appropriate management and need to thorough documentation of the drug reaction of patient safety for patient safety. Thanks.